Hello everyone. Today we will be discussing the topic of drugs affecting the cardiovascular and renal systems. Changes to general hypertension care. Newest clinical guidelines focus on patient outcomes, based on the understanding that if patients take their medications, it is more likely to have good clinical outcomes than if artificially selected numeric targets create falls, hypotensive episodes, and generalized fatigue. Targets for blood pressure readings must be individualized. New approach to targets. After serial blood pressure measurements indicate a persistent 150 to 160 millimeter mercury systolic blood pressure in individuals without other major deep vein risk. Medications are initiated after diet and exercise. Target values below 140 millimeters mercury systolic blood pressure are not rigidly enforced if adherence to medications and exercise have proven beneficial, especially in older adults with hypotensive episodes. Targets of below 140 millimeters mercury systolic blood pressure remain for patients with diabetes and mellitus. Emphasis on lifestyle change continues after medications are started. Treatment of hypertension with higher cardiovascular risk. Stage 1. Systolic blood pressure 140 to 159 millimeters mercury. Diastolic blood pressure 90 to 99 millimeters mercury. Diuretics, thiazide type. May consider angiotensin converting enzyme inhibitor, angiotensin receptor blocker, calcium channel blocker, or combination. Stage 2. Systolic blood pressure greater than or equal to 160 millimeter mercury, diastolic blood pressure greater than or equal to 100 millimeter mercury. 2-drug combination, thiazide type and ACE inhibitor, ARB, beta blocker, or calcium channel blocker, with compelling indications, heart failure, diabetes mellitus, stroke, chronic kidney failure, point of maximal impact, diuretics, ACE inhibitor, ARB, beta blocker, and calcium channel blocker as needed. Treatment of heart failure. Stage A. ACE inhibitors are the drug of choice. ARBs are considered but are more expensive. Stage B. ACE inhibitors in all patients, ARB for those who cannot tolerate an ACE inhibitor, beta blockers in most. Stage C. ACE inhibitor and beta blockers that are non-selective in all patients, diuretics, and digoxin. Spironolactone. Stage D. Sacubitril / valsartan, with the brand name being Entresto, in lieu of ACE or ARB. Ionotropes, dobutamine. Ventricular assist device, transplantation, and hospice. Pharmacodynamics. Inhibition of ACE activity through administration of ACE inhibitors results in decreased production of both angiotensin II and aldosterone. Angiotensin II has multiple roles in the cardiovascular system. It increases vasomotor tone by directly stimulating vascular smooth muscle contraction and through the inhibition of endothelial nitric oxide and prostaglandin release, raising blood pressure and decreasing blood flow through arteries, including the coronary arteries. Can lower vascular resistance without decreasing cardiac output or glomerular filtration rate. Does not produce reflex tachycardia. Strong evidence for cardiovascular and cerebrovascular risk reduction, heart failure, and slowing renal disease. Improves oxygenation to heart muscle. Decreases inappropriate remodeling of heart muscle after myocardial infarction or with heart failure. Reduces effects of diabetes on the kidneys. Improves insulin sensitivity, does not affect glucose metabolism, or raise serum lipid levels. This table shows the most common ACE inhibitors, with the initial dose and maximum dose. ACE inhibitor use for younger Caucasian patients. Patients with angina. Prevents formation of angiotensin II and decreases pulmonary vascular resistance by decreasing retention of sodium and water and reducing extracellular fluid and preload. Patients with diabetes. Prevents or slows nephropathy. After myocardial infarction and heart failure, for ventricular remodeling. ACE inhibitor use. Not as effective in African American patients. When combined with a diuretic, race is no longer an issue. However, there is 3 to 4 times greater risk of angioedema in African Americans and Asians. Adverse drug reactions include the following: dry cough, hypotension, loss of taste, angioedema, blood dyscrasias, teratogenicity, hyperkalemia, acute renal failure, cholestatic jaundice, pancreatitis, and rash. Monitoring. Baseline blood pressure and a pulse reading should be taken before initiating therapy and with each change in dosage. Weight and other indicators of fluid status should also be monitored. For ACE inhibitors, the white blood cell count with differential should be monitored before initiation of therapy, monthly for the first 3 to 6 months and periodically for up to 1 year for patients at risk for neutropenia, which includes renal impairment, collagen vascular disease, and high doses. Patient education. Administration. The drug should be taken exactly as prescribed at the same time each day. Missed doses should be taken as soon as remembered unless it is almost time for the next dose. Doses should not be doubled. Adverse reactions. Education concerning hypotensive reactions can reduce the risk of falls. Changing position slowly, not exercising in hot weather, and keeping fluid intake at more than 2 liters per day, non-caffeinated, will decrease these reactions. There is no effective treatment to date for ACE inhibitor-related cough. Changing to another ACE inhibitor or to an ARB may help. Hello everyone, today we will be continuing the topic of drugs affecting the cardiovascular and renal systems. Angiotensin II receptor blockers prevent binding of angiotensin II to receptors in the kidney, brain, heart, and arterial walls. Inhibit the renin-angiotensin-aldosterone system and cause fall and peripheral resistance. Evidence supports use in kidney disease until late stage and heart failure, but not all forms are renal protective like ACE inhibitors. No bradykinin-mediated cough like ACE inhibitors, considered alternatives for patients who cannot tolerate ACE or may become resistant, may be combined with hydrochlorothiazide. Pharmacokinetics. Losartan, with the brand name being Cozar, the prototype drug for the ARB class, undergoes extensive first-pass metabolism, resulting in 33% bioavailability. It may be taken without regard to food. Distribution is to most body tissues except the central nervous system. Losartan has both an active drug and an active metabolite, which is 5-carboxylic acid, that's hydrolyzed by the liver. Losartan has a 2-hour half-life, and its active metabolite has a 6 to 9-hour half-life. Dosing may be daily or in 2 divided doses. These are the most common ARBs with initial dose and maximum dose. Adverse drug reactions, similar to ACE inhibitors, typically no problem with cough. Monitoring, like ACE inhibitor, orthostatus with dose changes. Patient education, do not double dose if one is missed. Hypotension is the most common adverse drug reaction. Direct renin inhibitors, aliskiren, with the brand name being Tecturna, also works on the RAAS, can be used for hypertension, awaiting word on heart failure. not same myocardial infarction indication as ACE inhibitor and ARB, does not have the same renal protective properties as ACE inhibitors. For example, ACE inhibitors must stop when creatinine rises. Same issues in pregnancy, perhaps fewer issues with potassium and cough. Calcium channel blockers directly block the influx of calcium at the onset of the cycle, like the sodium channel blockade in local anesthetics. The blocking action of calcium channel blockers occur via three different receptors: diphenylalkylamine based and benzothiazepine based. Both are type 1 receptors, and dihydropyridine based, which is a type 2 receptor. Metabolism. All calcium channel blockers are extensively metabolized by the liver via the cytochrome P3A4 channel. Monitoring. Liver function should be evaluated before initiating therapy. Dosage reductions for most calcium channel blockers are recommended with severe hepatic impairment because of the extensive metabolism of these drugs by the liver. Monitoring heart rate, peripheral edema, and for heart failure symptoms is critical as well. Adverse reactions. Hypotensive reactions are the most common. Orthostatic precautions such as changing positions slowly, not exercising in hot weather, and ensuring intake of non-caffeinated fluids of more than 2 liters per day will decrease these reactions. Preventative action is required to alleviate the expected constipation. The patient should increase dietary fiber and fluid, if allowed. Stool softeners are prescribed prophylactically with verapamil and as needed with other calcium channel blockers. Patient education. Pregnancy Category C. Avoid non-steroidal anti-inflammatory drugs or NSAIDs, alcohol, and being in a jacuzzi alone. Gastroesophageal reflux disease symptoms get worse because of a decrease in esophageal tone. Cardiac glycosides. Digoxin, highly selective inhibitor of the adenosine triphosphatase, also known as ATPase system. Inhibition of this pump results in sodium and calcium buildup inside the cell, which leads to increased contractility of heart muscle. Serum concentrations greater than 1 mg per milliliter increase mortality. Initiate therapy at the lowest dose possible. New research shows digoxin may increase mortality in women. Benefits are best in patients with severe heart failure, enlarged heart, and third heart sound, and in patients who do not respond to ACE inhibitors and beta blockers. Digoxin is well absorbed orally. Taking digoxin with food, fiber, or after meals results in slower absorption. Digoxin is not extensively metabolized and is excreted largely unchanged by the kidneys. Its half-life is 36 to 48 hours with normal renal function. In the absence of oral or IV loading doses, steady state is achieved in about 4 half-lives, or 1 week. Several drugs, most notably quinidine, amiodarone, verapamil, and diltiazem, reduce clearance and can double the serum concentration, resulting in toxicity unless the dose of digoxin is reduced when those medications are introduced. Adverse drug reactions. The GI tract is the most common site of adverse drug reactions, including anorexia, nausea, vomiting, and diarrhea. These result from central nervous system actions, including chemoreceptor trigger zone stimulation. Other central nervous system-based adverse responses include fatigue, disorientation, and hallucinations, especially in older adults, and visual disturbances, including yellow vision and green halos around lights. The visual disturbances are considered classic signs of toxicity, but actually occur rarely. Atrial arrhythmias and atrial tachycardia with AV block are the most common signs of toxicity in children. Cardiac adverse reactions are extensions of the therapeutic action of these drugs. Bradycardia, junctional and AV block arrhythmias, premature ventricular contractions, and bigeminy. Gynecomastia is a rare adverse reaction. Monitoring. Routine monitoring of digoxin levels is generally overdone. Monitoring should occur in addition to clinical judgment rather than as a substitute for it. In general, testing should be done when any of the following occurs. 1. The patient is taking other drugs that may alter the pharmacokinetics of digoxin. 2. Steady state has been achieved, 4 to 5 half-lives or 1 to 2 weeks after starting a new dose. 3. Toxicity is suspected. 4. Confirmation of adequacy of maintenance dose is needed in situations of poor therapeutic response or patient adherence. 5. A reference point is needed in adjusting a dose. 6. The patient has progressive renal function decline. Serum electrolytes such as potassium, calcium, and magnesium, and renal status should be monitored concurrently, especially for patients who are also taking diuretics. Patient education. The patient should take the drug exactly as prescribed at the same time each day. The long half-life means that taking it at different times each day would be permissible, but the narrow therapeutic range means that missing a dose or doubling a dose could result in toxicity. If a dose is missed but remembered within 12 hours, it should be taken. If 2 doses are missed, the healthcare provider should be contacted for instructions. The drug should not be stopped or the dosage altered without first contacting the healthcare provider. Patients should learn to take their own carotid pulse and then contact the healthcare provider before taking the drug if the pulse rate is fewer than 60 or more than 100 beats per minute. Relying on a peripheral pulse counter may not accurately identify a pulse deficit. This may trigger an inaccurate withholding of a dose due to a low reading when dosing was still indicated. Patients are also typically educated on signs and symptoms of toxicity, including nausea, vomiting, diarrhea, confusion, irregular pulse, yellow vision, and green halos around lights. Hello everyone. Today we will be continuing the topic about drugs affecting the cardiovascular and renal systems. Arrhythmias are caused either by abnormal pacemaker activity or by abnormal impulse conduction. Normal heart rate depends on the intrinsic electrical impulses initiated at the sinoatrial node and conducted at the AV node and over the ventricles. Physiology. Absolute refractory period. Regardless of the strength of a stimulus, the cell cannot be depolarized. Relative refractory period. Stronger than normal stimulus can induce depolarization. Refractoriness. State of the cardiac cell which determines depolarization. Damaged heart cells may maintain a constant rate of refractoriness or may not be refractory at all. Specialized cardiac cells. Spontaneously depolarizing cells include SA nodes, AV nodes, His Purkinje, and special atrial cells. Automaticity. Ability of a heart cell to spontaneously depolarize and generate an action potential. May be altered, enhanced, or decreased by the following: cell damage, biochemical disturbance, pharmacological agents, and environmental toxins. Target for antiarrhythmic drugs. Re-entry phenomena. Re-entry is the cause of some arrhythmias. It depends on 2 anatomically or physiologically distinct electrical pathways. Normally, impulses from the AV node are conducted down both pathways in the same direction, bifurcating to cover the entire ventricle. If a block is encountered by the action potential in one of the pathways, then the impulse can only be conducted down the other pathway. The impulse can return to the initial point of bifurcation and re-excite the myocardium. Short-circuiting conducting tissue can occur and cause premature contraction. If reentry is repetitive, sustained ventricular arrhythmias, such as ventricular tachycardia, can occur. Pharmacodynamics. Class 1. Sodium channel blockers. A. Lengthen the duration of action potential. B. Shorten the duration of action potential. C. Minimally increase action potential. Class 2. Beta blockers. Reduce adrenergic activity in the heart. Sotalol, considered a Class 2 and Class 3 drug. Class 3. Potassium channel blockers. Prolong effective refractory period and reduce speed of conduction. Amiodarone. Class 4. Calcium channel blockers. Block the influx of calcium, reduce contractility. Negative ion tropism. Decrease SA and AV node conduction. Significantly reduce afterload but little effect on preload. Verapamil, diltiazem, and bupriodil. Antiarrhythmic agents. The table on this slide shows the different antiarrhythmic agents, with the left-hand side showing the different classes, while the right-hand side shows the different drugs within each class. Drugs for arrhythmias. Consult with cardiology team. Pharmacological management of arrhythmias requires an office that is prepared, ready, and able to handle emergencies. You will see these patients for infections, depression, anemia, fatigue, and so on. Be aware of actions and adverse drug interactions. Beta-adrenergic blockers. Various types include nonspecific beta antagonist, selective beta antagonist, and those with or without intrinsic sympathomimetic activity, also known as ISA. In post-myocardial infarction patients, cardioselective agents without ISA are preferred. Some are used as antiarrhythmics. Drugs with ISA may help avoid a decrease in cardiac output and heart rate, may be preferred for patients who experience bradycardia with other beta blockers. More effective in African American and older patients. Beta blockers may not be abruptly withdrawn because it will increase beta receptor sensitivity. No longer first-line hypertension drug choice. Amiodarone, also a Class 3 drug, has significant properties of several other classes as well. Pharmacodynamic/kinetics. Onset of action, oral 2 days to 3 weeks. Duration of action, 7 to 50 days. Excreted in feces and 1% in urine. Dosing. Watch out for use of grapefruit juice. Ventricular arrhythmias. 800 to 1600 milligrams twice daily for 1 to 3 weeks, then decrease to 300 to 400 milligrams twice daily. Maintenance 400 milligrams per day. Adverse drug reactions. Thyroid, neurological, blue skin discoloration, bradycardia, and lung damage not evident until advanced. Drug interactions, many. Monitoring. Laboratory data. Potassium concentration in the extracellular space is the major determinant of resting membrane potential and membrane stability. Levels should always be checked and kept mid-range, more than 4 milliequivalents per liter, for patients with rhythm disturbances. Renal and hepatic functions such as blood urea nitrogen, also known as BUN, creatinine, and transaminases are monitored because they are the principal routes of excretion for antiarrhythmic drugs. Electrocardiogram. Monitoring 12-lead electrocardiograms for indications of efficacy and toxicity is essential, especially concerning drugs for which ECG changes are the primary indicators of such problems. Patient education. The patient should take the drug exactly as prescribed. For doses taken more than once daily, the doses should be evenly spaced. Abrupt withdrawal of these drugs may result in life-threatening arrhythmias, hypertension, or myocardial ischemia. The patient should keep enough medication on hand for weekends, holidays, and vacations. Monitor heart rate for regularity of rate and rhythm. Monitor blood pressure at home. Nitrates. Nitrates were first introduced for the treatment of angina in the 19th century. Their ability to affect both oxygen supply and demand and their effectiveness in rapid relief of acute angina has made them one important part of the treatment for this disorder. All parts of the vascular system, from larger arteries to large veins, relax in response to nitrates. Nitrates affect the supply-demand equation on both sides. Dilation of venous capacitance vessels results in decreased systemic vascular resistance, afterload, venous pooling, and decreased venous return to the heart, which leads to decreased preload. Arterial dilation, which occurs more commonly with higher doses, decreases systemic arterial pressure, resulting in decreased afterload. Together, these effects decrease myocardial oxygen demand and increase myocardial oxygen supply. Nitrates have little effect on atherosclerotic coronary arteries. Adverse drug reactions. The major adverse reactions are direct extensions of therapeutic vasodilation, orthostatic hypotension with potential for syncope, tachycardia, and throbbing headache. Hypotension may result in decreased diastolic filling pressure, and the tachycardia may result in decreased diastolic filling time, leading to myocardial ischemia, arrhythmias, and rebound hypertension. Headache may be severe and persist in up to 50% of patients. Drug interactions. Additive hypotension is possible with other drug classes that have actions or adverse effects of hypotension. Nitrates decrease the pharmacological effects of heparin. Concurrent use with vasodilators or with erectile dysfunction drugs. Sildenafil, with the brand name being Viagra. Tadalafil, with the brand name being Cialis. Or vardenafil, with the brand name being Levitra, contraindicated. Sublingual NTG has rapid action, long-established efficacy, easy use, and low cost. A disadvantage is its short duration of action. It is also volatile and must be kept in a tightly capped amber-colored glass container and stored in a cool place. Onset and duration of action of a single meter dose of translingual spray is about the same as for sublingual NTG. Transdermal delivery systems offer easy use and release NTG at a constant rate to maintain steady-state plasma levels. In generic form, the cost of NTG sublingual is low. Chewable forms provide more rapid onset of action, but the duration of action falls to about 2 hours. Clinical use and dosing. Acute angina attack, use NTG. Sublingual NTG, a short-acting form, 0.4 to 0.6 milligrams every 5 minutes for up to 3 doses. Stable or predictable angina. Use isosorbide. Isosorbide dinitrate, 10 to 40 milligrams orally 2 to 3 times daily. Sustained release form 40 to 80 milligrams daily. Isosorbide mononitrate. Dosing is 20 milligrams twice daily. Eccentric scheduling to avoid development of tolerance. Patient education. Take the drug exactly as prescribed. Eccentric dosing schedule is separated by 7 hours because of need to have nitrate-free period. Take at 7 to 8 a.m. and 2 to 3 p.m. rather than usual twice daily regimen. A nitrate-free interval of 10 to 12 hours is needed. If anginal symptoms occur at night, have a daytime nitrate-free interval. Storage of NTG. Adhere to the expiration date on the bottle, usually 6 months. Do not open the bottle frequently or keep bottles of tablets next to the body, for example, in a shirt pocket. Hello everyone. Today we will be continuing the topic of drugs affecting the cardiovascular and renal systems. Peripheral vasodilators. Peripheral vasodilators are used to treat resistant hypertension and PVD. Although significant clinical improvement of PVD rarely occurs with these drugs alone. The focus of the discussion here is on the two remaining peripheral vasodilator drugs. Hydralazine, with the brand name being apresilane, and minoxidil, with the brand name being Lonatin. Both are seldom used adjunct therapies, not first-line hypertension medications. Peripheral vasodilators are useful in the treatment of hypertension, act by direct relaxation and dilation of arterial smooth muscle, thereby decreasing PVR. They do not dilate the epicardial coronary arteries and do not relax venous smooth muscle. Minoxidil is considered the more potent. Adverse drug reactions related to compensatory responses in the sympathetic nervous system and RAAS, tachycardia, increased cardiac contractility and output, sodium and water retention, and headache. Drug interactions, additive effects with other antihypertensives. NSAIDs may decrease their effect. Dosing. Hypertension. Hydralazine 25 to 100 milligrams 4 times daily. Maximum dose 200 milligrams per day. Peripheral vasodilators. Monitoring recommendations. Most patients should return for follow-up and adjustment of medications at monthly intervals or until the blood pressure goal is reached. Serum potassium and creatinine should be monitored at least 1 or 2 times per year. After blood pressure is at goal and stable, follow-up visits can usually be at 3 to 6 month intervals. Comorbidities such as heart failure, associated diseases such as diabetes, and the need for laboratory tests influence the frequency of visits. Other cardiovascular risk factors should be monitored and treated to their respective goals, and tobacco avoidance must be promoted vigorously. Low-dose aspirin therapy should be considered only when blood pressure is controlled because of the increased risk of hemorrhagic stroke when hypertension is high. Hello everyone. Today we will be continuing the topic about drugs affecting the cardiovascular and renal systems. Atherosclerosis is the major cause of CVD. It is characterized by deposits of cholesterol and other lipoproteins on the walled arteries. 4 major classes of lipoproteins are found in the serum of fasting individuals. Low-density lipoproteins, or LDLs, high-density lipoproteins, or HDLs, very low-density lipoproteins, or VLDLs, and triglycerides. Exogenous pathway involves absorption of lipids via intestine. Endogenous pathway. Lipids originate from liver. LDL receptors in the liver are downregulated by the presence of LDL. Therefore, one mechanism for lowering LDL is drug therapy that increases the number of LDL receptors in the liver, such as bile acid binding resins and 3-hydroxy-3-methylglutarol coenzyme A, also known as HMG coenzyme A reductase inhibitors. Drugs affecting LDL, HDL, and triglyceride levels differentially. Their clinical application is based on how they affect each of these. There are 4 general classes of lipid-lowering drugs. Fibric acid derivatives, bile acid, sequestrants, Competitive inhibitors of HMG coenzyme A reductase and the PCSK9 inhibitors. Niacin, once another class of cardiovascular medication, has been taken off of the guidelines because it had some HDL increase evidence, but no evidence of any decrease in all-cause mortality or cardiovascular event reoccurrence when used. Ezetimibe, with the brand name being Zetia, blocks the absorption of cholesterol across the intestinal border. This results in a 12% reduction in LDL. However, it is not considered a first-line therapy except in children with familial hypercholesterolemia. Vitamins, antioxidants, herbs, and natural products. Vitamin E, vitamin C, folic acid, garlic, fish oils, fiber, coenzyme Q10, and flaxseed. Active liver disease is a contraindication for all except bile acid sequestrants. Statins, HMG coenzyme A reductase inhibitors, block synthesis of cholesterol in the liver by competitively inhibiting HMG coenzyme A reductase activity. Decrease levels of LDL by 25% to 65%. Modest decreases in TGs, 10% to 40%, and very modest increases in HDL, 5% to 17% may occur. Pregnancy, old category X, fully contraindicated. Statins, cytochrome 3A interactions. All statins except fluvastatin and rosuvastatin are metabolized at least in part by cytochrome 3A. Cytochrome 3A inhibitors may increase statin concentrations. Verapamil, diltiazem, azole antifungals, erythromycin, fluoxetine, nifazodone, and protease inhibitors. Cytochrome 3A inducers may decrease statin concentrations. Rifampin, phenytoin, and phenobarbital. Statins may also interact with other cytochrome channel substrates, for example, cyclosporin. Statin, adverse drug reactions, common, headache, myalgia, fatigue, GI intolerance, and flu-like symptoms. Myopathy, occurs in 0.2% to 0.4% of patients, some agents more likely. Reduced by using lowest effective dose. Cautiously combine statins with fibrates. Avoid drug interactions. Increase in liver enzymes not enough to warrant frequent laboratory tests. Active liver disease is a contraindication. Occurs in 0.5% to 2.5% of cases and is dose dependent. Serious liver problems are rare. Managed by reducing dose or stopping until levels return to normal. Statins, HMG coenzyme A reductase inhibitors. Start with lower dose and increase as needed, according to LDL response. Absolute levels of LDL not as closely monitored now. Rosuvastatin, most potent, 5 to 20 mg per day. Atorvastatin, next most potent, best adverse drug reaction profile. 10 mg per day initially, increase no fewer than 2 to 4 weeks. Simvastatin, 20 to 40 mg per day. Lovastatin, IR, 20 mg per day. XR, 40 to 60 mg. Pravastatin, 40 mg per day. Pediatric dosing for children 8 to 13 years, 20 mg per day. Doses often are given traditionally in the evening/bedtime. May need to decrease dose occasionally. When adding potentially interacting drug, profound drop in LDL. Statins. Monitoring. Lipid levels in 4 to 6 weeks, then every 3 to 4 months until control established. LDL levels guide dose increases. Liver function tests, also known as LFTs, before starting therapy and 3 to 6 months later, only if suspected issues or underlying hepatic issues. Patient education. Lifestyle changes that include diet and exercise. Hello everyone. Today we will be finishing up the topic about drugs affecting the cardiovascular and renal systems. Diuretics. Thiazide diuretics. HCTZ. Chlorothalidone. Indapamide. And metolazone. High-dose therapy, HCTZ greater than 50, has increased risk of hypokalemia, increase in uric acid levels, and serious cardiovascular outcomes. Use in combination versus pushing high doses. Watch with patients with hyperlipidemia. Loop diuretics. Potential for cross-sensitivity with sulfa. Furosemide, bumetanide, and torsemide. Potassium sparring, often used in combination with thiazide to reverse low potassium effect. Triamterene, spironolactone, and eplerenone, with the brand name being Inspira. Adverse drug reactions. Electrolyte imbalances are common in all diuretic classes. Thiazide and loop diuretics cause hypokalemia and may cause hypercalcemia, hyponatremia, and hypomagnesemia. When it occurs, the hypomagnesemia must be corrected first to permit successful treatment of the hypokalemia. Hypotension secondary to fluid volume deficits can also occur with all diuretics. Starting with a low dose and increasing the dose gradually can reduce this problem. Instructing patients that oral fluid reduction is not indicated with these medications can help in this regard. Monitoring. Blood pressure, heart rate, edema, weight gain, dyspnea, cough, and urine output. Prior to initiating therapy, BUN, creatinine, electrolytes that include sodium, potassium, calcium, and magnesium, uric acid, and glucose levels. Ongoing monitoring of electrolytes. Patient education. Take as directed early in day if there are urination issues. Do not skip or double dose. Monitor weight. Must drink fluids.